Good morning. I am Dr. Halesh LH, Professor of Microbiology, Siddhartha Medical College, Tumkur. Today, let us know about the malaria. As we know, malaria is a burning problem globally, and this malaria, the word itself, malaria, that is the bad air. Earlier, when the causative agent was not known, people thought, and this disease was in the marshy, wet areas, then people thought disease spreads by the bad air. Hence, it was called malaria. Later, Leveron in 1880, he found some parasites in the RBCs. After that, in 1897, the Ronald Ross, that too in India, Sikandrabad, he found mosquitoes, female Anopheles mosquitoes are responsible for the disease malaria. So this is the brief history. From there onwards, we have found that it was there now it is almost in under 108 countries they are affected by this disease malaria, and most of the African countries and the Southeast Asian countries are worst affected, including India. So this malaria is caused by the parasite Plasmodium, a protozoa, or the sporozoa it is called, and it has 4 important species which can cause malaria in the human being. Of course, there was a 5th. Recently, it was found that the Plasmodium novesi, that is more common in the monkeys or the chimpanzees, but few cases in the human beings are also seen. But the important one are the Plasmodium falciparum, Plasmodium vivax, Plasmodium malariae, and Plasmodium ovale are the 4 important species which can cause infection in the human beings. And here only there are 2, that is the tertian type and the quartan type of malaria are there. So tertian means every 3rd day the fever starts, hence it is called tertian. Whereas in the 4th day if it starts, it is called the quartan. Only the Plasmodium malariae which has got the quartan type of malaria, otherwise all will have the tertian type of malaria. And among this, the Plasmodium falciparum has got the more complications, hence it is called malignant tertian malaria. So epidemiologically, as we know, as on today, there are about more than 250 million infections occur worldwide, and more than 1 million deaths in the world are due to the malaria, and this shows the geographical region where the malaria is endemic. So coming to the vector, is the female Anopheles mosquito is responsible for the transmission of the disease, and about 60 species are there, in which the very few very few species can lead into the disease. In the resting position, the female Anopheles mosquito takes that position for the identification of the mosquito. Coming to the life cycle, as we know, the human beings are the definitive host for most of the parasitic infection. In very few conditions, man is intermediate host, in which the important one is the malaria, where the man is intermediate host. Next one is toxoplasma, and one more is the dog's tapeworm or Echinococcus granulosus. So here man is the intermediate host, whereas female mosquito, Anopheles mosquito, is the definitive host. That is the important thing to be known. Coming to the life cycle, it has got human life cycle and also mosquito life cycle. In the human life cycle, actually again it is divided into pre-erythrocytic schizogony, and there is erythrocytic schizogony and the gametogony. These 3 phases they occur in the human being, whereas in the mosquito it is called the sporogenic or the sporogony. So now a infected mosquito, when it bites the individual, so the sporozoites are the infective elements, and these sporozoites enter our circulation and they will go to the liver cell. So in the liver cell hepatocytes, they transform into the schizons, and each cell will have, in case of falciparum, 30,000 merozytes are produced in the each cell, whereas in the vivax it is about 10,000. In others there will be 15,000. So each hepatocyte will form, I will have the 15,000 to 30,000 merozytes, and these merozytes will rupture, the cells will rupture and they release the merozytes, then the erythrocytic cycle starts. So this one is the pre-erythrocytic, this occurs in the liver. After that it will come to the RBCs. So in the RBCs, all the merozytes which are ruptured from the liver cell, they will attack the RBCs. So they have the specific receptors over the RBCs, and the merozytes will be taken inside by the endocytosis. Once this is taken inside by the endocytosis, so we can see that the early trophocyte form, they are called the ring form. Those are the, this is the ring form. Okay. So these ring form will go into the amoeboid form. So early trophocyte, this is the late trophocytes where the amoeboid forms are formed. Then it will become the schizont, and these schizonts in the RBCs, depending upon the species, about 8 to 32. Usually in the falciparum the numbers are more. Here also in the pre-erythrocytic cycle in the liver cell, falciparum will have 30,000 in each cell. Here also it is about up to 24 to 32 merozytes. They will rupture. See, all the RBCs which are infected, synchronously they will rupture. This takes about 48 hours. So when they rupture, there is a release of all the merozytes, their metabolites and toxins that are released. Okay. So these are engulfed by the macrophages. When the toxic products are engulfed by the macrophages, they will release the interferon and also tumor necrosis factor, that is interferon 1, and this interferon 1 is a pyrogen. So naturally this pyrogen, when they are released, they will reach the hypothalamus and immediately there is a fever, high degree fever, because the pyrogens are released. So these cycles continue every 48 hours in case of Plasmodium vivax, falciparum and ovale, except the Plasmodium malaria where it takes 72 hours. But the fever appears every third day, hence it is called tertian in case of vivax, falciparum and malaria, in the ovale, whereas in the malaria every fourth day fever appears. So that periodically these cycles will occur, about 7 to 10 such cycles will occur. In the meantime, after about 5 cycles, because the body will get the resistance by that time, some of these parasites, they will go for gametogony or the gametogenesis. So they will form male and female gametes, and they will be present in the blood for about 3 months. They will be alive in the blood, and these gametocytes are in the blood in such individual. So this is about the cycle in the man where the schizogony, pre-erythrocytic schizogony and the erythrocytic schizogony occur, and gametogony is also occurred here only. Now in this patient, when the female mosquito, Anopheles mosquito, bite such person, it will take all the RBCs, asexual and the sexual gametocytes. So naturally all others are digested except the gametocytes. So here the gametocytes are male and female gametocytes. This is belong to the falciparum. Other, this one will be round, whereas here it is sickle shaped. So these gametocytes, the male gametocytes, they will go by a process called, so they are sucked by the mosquito and they will go by a process called exflagellation. In the exflagellation, there are thread-like small microgametes. They are highly motile. So about 8 gametocytes are microgametes are released, whereas the macrogamete that will increase in size, it gets matured. So one microgamete will fertilize one macrogamete and it forms a zygote. So this zygote, after about 24 hours, it will become ookinete. Ookinete means it will have the motility, it will get elongated and it becomes motile. And this ookinete, it will pierce the stomach wall of the mosquito, come to the outer margin of those cells, and it will grow into oocyst. In the oocyst, thousands and thousands of sporozoites are formed, and ultimately the oocyst will rupture and releasing into the sporozoites. So thousands of sporozoites are in the blood. That time a mosquito, if it sucks the blood, these sporozoites, these sporozoites are released in the mosquito itself. So after the rupture, they will go in the body cavity, they are released, and ultimately they will come to the salivary gland of the mosquito, and that is the infective one. One such mosquito bites the man, then the sporozoites will enter and they will go to the liver, and the pre-erythrocytic cycle occurs, and post-erythrocytic the cycle continues. This is the life cycle of malarial parasite. So here while the paroxysm, the fever, every 48 hours there is a fever in case of vivax, falciparum and ovale, whereas every 72 hours there is a fever in case of plasmodium malaria. It is a what type of fever? It is an intermittent fever. When it occurs, when the RBCs they synchronize, that is the rupture synchronously, that time because of the release of the toxins and the metabolites of this one and the action of the macrophages release interferon gamma, the fever occurs. So that is about the, except in case of plasmodium malaria it will have the quartan type of malaria. So these other three will have the tertian type of malaria. Okay. So now the vivax will have benign tertian malaria, falciparum will have benign also, but if the number of cells which are infected are more than 5% of the RBCs, it can go for the malignant type and leading into the complications. And plasmodium malaria, there is a quartan malaria, it can happen, and also ovale will have the tertian malaria. So now coming to the individual one, where the plasmodium falciparum it is the one which is more dangerous because it goes for malignant tertian malaria, otherwise it is called the pernicious malaria. It has got lot of complications. So 80% of the malaria cases in the world are the plasmodium falciparum globally, whereas in India among the 50%, almost falciparum is about 40%, reaching the 50, and other vivax is the other 50%. So here it is called falciparum because the gametocytes are sickle shaped or the banana shaped, that is why it is called the falciparum. So here in the ring forms, there is a multiple rings. Rings are very small and they are more, up to 2 to 6 rings are seen in the each RBCs, and there is a ecoliforms. Ecoliforms means a portion of the ring will come out of the RBC, then it is called the ecoliforms. They are seen, okay, and the infected size are normal in, because all stages of the RBCs are infected, hence they are the normal in size. And there are some dots in the RBCs, they are called the Morer's dots, and in the each RBC will have the rosette forms of the merozoites. They are about actually it is more about 24 different types of merozoites are seen in the rosettes. So as I told you, the gametocytes are crescent shaped or the sickle shaped or the banana shaped, that is depicted here. These are the gametocytes which are seen. So the 3 weeks after the infection, these gametocytes will appear in the blood, and these are the multiple ring forms which are shown. This is the gametocyte. Now coming to the plasmodium vivax. So vivax causes benign tertian and mainly seen in Asia and America. In India, as I told you, nearly 60% are the vivax only. And it has again in the pre-erythrocytic cycle, the mature schizonts will have about 10,000 merozoites, whereas in case of falciparum it is the 30,000. And again here the early RBCs are infected, that is why RBC side looks bigger, whereas in case of falciparum they are the normal RBCs. Here the RBC size is bigger because the reticulocytes are infected, that is number one. Number two, the parasites or the ring forms are only usually single, whereas in case of falciparum multiple infections can be seen, and it is the Morer's dots are seen, here it is the Schaffner's dots are seen with the mature parasites. So here the amoeboid form is called the early trophozoite, and then there is a schizont form, and these schizonts form later it will go for the rosette form, and here the amoeboid form is depicted here. See that ring form will become the amoeboid, and these are all the Schaffner's dots we can make out. So then comes to the oval. It is seen in the African countries where the few cases are reported in India where the RBCs will be oval, and then it is called the oval, more common in West Africa. So here the RBC size is same. Next, malaria, it is where in the malaria the characteristic feature is instead of amoeboid form there is a band form. So in Karnataka also it is especially in Tumkur and Mandya district and Hassan we can find this type of malaria where the band form is there. So this is the one. So this is about the malaria. Okay. So here the complications due to Plasmodium falciparum, that is the malaria, is the nephrotic syndrome is important complication of the malaria. Otherwise it is a mild infection which can occur, and very few, the 1% of the RBCs are infected. So in brief, that is the Vivax. Usually in the liver cycle, the days taken in the liver is least is falciparum and the maximum is malaria, and the number of merozoites in the hepatocytes are 30,000 in case of falciparum and 10,000 in case of oval, the Vivax, and oval and malaria are about the 15,000 parasites. So coming to the erythrocytic schizogony, as I told you, except in malaria 72 hours, others will have 48 hours cycle, and ring forms. So again here except the falciparum, where in the peripheral blood smear only we can see ring forms and the gametocytes. The amoeboid form or the schizonts are not at all seen in the falciparum, because this falciparum, and it is also have the complications. Why it is having complications? Because falciparum, after the ring form, when it enters the blood, they will go to the deeper organs in the capillaries. They produce one antigen, that is the Plasmodium falciparum erythrocyte membrane antigen 1. So this antigen is having the predilection to adhere to the endocytes of the capillaries. That's why after the ring form, all will go to the, when they enter the internal organs in the capillaries, they will bind and they will clog or block the capillaries. So hence they will, clotting occurs and inflammation occurs, and due to the blocking hemorrhage occurs. That's why the complications are more. So except in case of falciparum, only ring form and gametocytes, in all other three other forms like the schizonts are also seen. So in the RBCs, as I told you, falciparum is the maximum. Each RBC will have 18 to 24 merozoites in the form of the rosettes. So these are the different stages in the RBC, where falciparum is the important one. The multiple infections are, there is a E. coli formation, and there is a gametocytes, banana shaped or the sickle shaped banana cytes. Except this stage, these two stages are not seen because they are in the internal organ capillaries. Whereas in the Vivax, that is you can see the single infection and the amoeboid form, and in case of malaria, this is the band form. This is the classical one which is seen in our place, Tumkur and Hassan district. It is in Karnataka they have seen. And coming to the oval, you can see the oval shaped RBC with the fenestration, that is the classical structure. So this is about the malaria and its life cycle and also epidemiology. Let us know about the disease itself, that is the malaria. See, malaria, so it is transmitted naturally by the bite of female Anopheles mosquito. So other than the bite of mosquito, can malaria spread? Yes. So that can spread by the other methods, we will know that. So naturally by the bite of the female Anopheles mosquito, that we know. Okay. So whereas other than bite of the mosquito, can a person get? Yes. So there are certain conditions, as in case of Uh, so in case of blood transfusion, the person who is having the malaria, if he gives the blood, this one, so such blood is transmitted, then the person who gets the blood, he will have the malaria. Only thing is, liver cycle will not be there. Directly he will go for the the RBC cycle. Similarly, when the mother is having the malaria during the delivery, that will be transmitted to the child. So congenitally also it can be transmitted, or usage of common usage of the single syringe in the drug addicts and other this one, they can also have this. So without the mosquito bite, they can also have the malaria. So there is no liver cycle here. That is the important thing. So these are the one: transfusion malaria, drug addicts, and also congenital malaria, as I already explained. So in the pathogenesis, in the benign malaria and also falciparum malaria. So benign malaria in the pathogenesis, so they will have fever is the first factor, that is in the paroxysms. Paroxysm means every 48 hours person will have the fever. So in the paroxysms it will come, and it is called the intermittent fever. Whereas in case of falciparum, so here also in the benign there is a fever, there is anemia, there is splenomegaly. These are the three important features you can see in case of benign malaria. Whereas in the falciparum, addition to this, because the blockage of the capillaries in the internal organs occur, it goes for the complications like cerebral malaria, algid malaria, septicemic malaria are the complications which are caused by the Plasmodium falciparum. So as I told you, these are the benign malaria. It can occur in case of vivax, ovale, and also malaria. And here the clinical features, as I told you, the fever. See the fever, why it occurs? Because the synchronously RBCs are ruptured. There is the release of the merocytes with the metabolites and also the toxins. They are taken by the macrophages. And these macrophages will release pyrogen, that is the interleukin 1 and also the tumor necrosis factor. So this pyrogen will set the hypothalamus into the higher temperature. So the person in the fever incident, person initially he will have the, suddenly because the hypothalamus has set the temperature at 40 or 41 and body temperature is 37, there is a difference. So body has to regain that temperature, it has to reach that temperature, hypothalamus set temperature. So it will go for the chills and rigors. To gain that temperature, person will have severe cold, chills and rigors. So it will happen 15 minutes to 1 hour, the person will have very cold and chills and rigors. So now the body temperature will rise to 41. So it will have few hours of temperature, high degree fever. After that high degree fever, now all the metabolites are cleared. When it is cleared, hypothalamus will set the temperature to 37 again, but the body temperature is 41. But it has to give away the temperature, then it will go for the profuse sweating. So earlier there is a cold stage, then the hot stage, the fever is there, then you will got the wet stage or the sweat stage, where person will have profuse sweat, and this it is so person will be drenched with the sweat, blankets, bed sheets, everything will be wet. So after that he will go for a very nice sleep, and morning he gets up and he will be very fresh. Another 48 hours he will be very normal. After 48 hours again you will get. So that is the intermittent, up to 7 to 10 such cycles of fever can occur in the each infection. That is the fever stage. Next comes the anemia. Why anemia occurs? Because RBCs are involved, thousands of RBCs are ruptured, that is one cause. Not only that, it involves the erythropoiesis is affected, because the reticuloendothelial cells are affected, even the bone marrow is affected, then the erythropoiesis or the production of RBC itself is affected. Not only that, the infected RBC and also the non-infected RBCs are having the antigen antibody complex covering over that, that is cleared by the spleen. Hence, all these factors lead into the thing, that is the fever, anemia is there, and splenomegaly is there. These are the things which are appear in the normally or the benign type of malaria. So whereas in case of falciparum malaria, other than this, because of the blockage of the capillaries in the organs, it may occur in the brain, leading into cerebral malaria. So, person will have the cerebral malaria, because in the cerebral malaria, the number of up to 30 to 40% of the RBCs are involved. There is a blockage of capillaries, rupture and blockage in the brain leading into the cerebral malaria. Patient will have confusion, delirium, headache, nausea. With that, so he will go for the coma, and even after treatment, the most of the cases will die because of the cerebral malaria. So, like that, other organs are also involved, like the cerebral malaria. There is a algid malaria where there is a rupture of the adrenal glands leading into the adrenal rush. So, that will lead into the hypotension. So, cold clammy body and the periphery with the hypotension, person will go for, that is called the algid malaria. Person may die with hypotension. There is a septicemic malaria because the multiple organs are involved with the continuous high degree fever, the renal failure, liver, kidney, everything can occur. So, leading into the septicemic malaria. These are the complications which are seen. So, cerebral, algid and the septicemic. And I have already explained about the cerebral malaria. So, where you can see the brain section where the showing the hemorrhages there because of the blockage of the capillaries in the brain. So, naturally the survival chances are very meager even after the treatment. This is about the adrenal algid malaria because the adrenal damage can occur leading into the hypotension. Similarly, septicemic malaria, usually the multi-organ failures can occur in case of septicemic malaria. So, there is a condition in malaria called black water fever, that is also a complication only due to falciparum, malarial falciparum. It is due to repeated infection or incompletely treated with the quinine. Naturally, there is a production of autoantibodies against the RBCs. That is why, so when the second or third term or repeatedly when the infection occurs, RBCs will lyse massively leading into hemoglobinuria. Because of the iron product in the urine, urine will be black in color, hence it is called black water fever. It is a complication due to this. That is also same thing, repeated falciparum infection leading into hypersensitivity, erythrocytic antibodies are produced, intravascular massive hemolysis occurs, RBCs are destroyed and hemoglobinuria can occur, and because of hemoglobinuria there is hemoglobinemia. So, person will have the anemia because of that. So, there is a word, two words I have to mention here, one is relapse and another one is recrudescence. Relapse means, see, the sporozoites from the mosquito when they enter the hepatocytes in the liver, all the sporozoites will not have the erythrocytic phase. Some of them will hide there. They are called the hypnozoites. Hypno is that sleeping. So, some will sleep there for months and years. They will not come for the RBC. Hence, it is called the hypnozoites. They will cause the relapse after a few months or the years. Hence, it is called the relapse. This can happen in case of the vivax and also the oval. Whereas recrudescence, what is this recrudescence? Even other than vivax and the oval, malaria and falciparum, there can be again the infection after the up to 5 years. Why it can happen? Because of the recrudescence. Recrudescence means they will be present in the subclinical level in the RBCs. They are not in the liver. This malarial cycles will be there in the RBCs subclinically. Because of the immunity, they will not come to the surface. After few months and years, so it can come to the surface, then it is called the in those time the cytoplasm will be blue in color, whereas nucleus will be red in color. So, we can make out here, I have already given the explanation of all the gametocytes shapes and also band form, schizons, how it looks and all. So, by this we are going to, so what is the advantage of thin smear here? Because you can speciate, we can know which species it is. So, whereas the thick smear, the advantage is, so it is a 40 different layers of the blood will be there, we can easily, so it is a more specific, whereas thin smear they are sensitive, thick smear is sensitive, whereas thin smear are specific, you can speciate the thing. So, whereas peripheral blood smear disadvantage is experienced microscopist is required, whereas in case of thin smear only, if it requires more than 200 parasites per microliter for its detection, that is why that is the drawback of this one. Otherwise, this is the gold standard detection of the parasites in the so this is how the different ring form is there, amoeboid form is there, schizont is there, and gametocytes are there. These are the different forms of malaria. Similarly, in falciparum, you can see the multiple rings and E. coli formation, gametocytes, and malaria there is a band form, and in the oval they are the oval RBCs are seen. So, next is the quantitative Buffy coat technique. In the quantitative Buffy coat technique, what we will do, there is a capillaries coated with the acridine orange, and these blood is sucked from the capillary and is subjected for the centrifuge 12,000 rotations per minute, and it will have the different layers, RBC layer, WBC layer. So, the acridine orange will stain the nucleus. So, WBC nucleus is stained, RBC they are not stained. In between the junction there is a parasitized RBCs which will show the DNA that is detected in the bright green in color. This is about the quantitative Buffy coat technique, highly sensitive one. So, next there is a detection in case of rapid diagnostic method where the immunochromatography methods are there, where it can detect all the four can be detected by parasite lactate dehydrogenase, whereas specifically falciparum is detected by histidine rich protein 2. So, that is detected. So, these are the some of the tests where, so just we will go through this. So, in the negative only control is band strip is band is colored, whereas this is for the anti-falciparum, this is for the anti-malaria. So, all the four are detected here, only falciparum is detected here. So, when the only the LDH, that is the T2 is there, so other than falciparum. If all are there, yes, it can be falciparum. So, that is how we can interpret this antigen detection test, where all the four are detected by the lactate dehydrogenase, all the four will produce, whereas histidine rich protein 2 is produced by falciparum only. So, you can directly detect by these methods. So, they are very simple, anywhere you can detect, only the drawback is sensitivity. So, it requires more than 100 parasites in case of LDH detection and more than 40 parasites in case of histidine rich protein detection. That is the drawback of that, otherwise easy and convenient. So, coming to the yes, again disadvantage I have told. So, antibody detection do not have much role, only it says that past infection it will identify. It is for the diagnosis it is not of much use. Then culture only again for the research purpose, where Traeger and Jensen co-cultivation method is applied, only that is RPMI 1640, that is Roswell Park Memorial Institute 1640 media is used there only for this one. Then the drugs which are used usually quinolines, that is chloroquine, quinine, mefloquine, primaquine are used, and similarly because of the resistance to chloroquine and chloroquine mainly, so we are going for artemisinin derivatives of the drugs for the treatment. So, there are even pyrimethamine, sulfadoxine, all these drugs are used in the malaria. So, the treatment of Vivax mainly the chloroquine 25 mg per kg divided over 3 days, that is 10 mg per kg first day and second day, and 5 mg per kg third day, that is the chloroquine. It will kill the RBC stages, it will not kill the liver stages, that is the hypnozoites are not killed by this. That is why in case of Vivax and Oval, we have to treat later. So, the primaquine for about 14 days, we have to give the primaquine 0.25 mg per kg body weight for the 14 days only to kill the hypnozoites. This is about for the Vivax treatment. Whereas coming to the falciparum, so here again the treatment for northeast state it is differ from the other states. See, in the northeast state there is a chloroquine resistance is seen That is why where we will use the artemisinin, with that we can use the lumefantrine drug. Okay. Then even then they are not having the hypnozoites, we give primaquine only single dose 1 day, because to kill the gametocytes, that is the method. Whereas in the other states the artemisinin, with that we can use the pyrimethamine and also the sulfadoxins are used, and the primaquine has to be given only single dose to kill the gametocytes. That is the nature. This is about the almost the treatment I have told you. So prophylaxis, there is a chemoprophylaxis, vector control strategies, and the vaccine prophylaxis. Chemoprophylaxis are the short term chemoprophylaxis where doxycycline is recommended. Similarly, there is a long term prophylaxis, we can give the mefloquine, that is the chemoprophylaxis. Whereas vector control, the adult controls using the pesticides like DDT, malathion, etc. We can control the adult mosquitoes, and there is a pesticides, the fogging using the chemical, and individually we have to use the mosquito nets and also clothing, proper clothing, and also the repellents, mosquito repellents can be used. Next is larval control. Usually we use the mineral oils, that is the Paris green, to kill the larvae in the drainages, etc. And the source reduction, it have to be made by the proper drainage system. And biologically we can use Gambusia fish to eat the larvae, and also the Bacillus thuringiensis, a bacteria which can kill or lies the larvae. This is the, whereas coming to the vaccination is very difficult in malaria because it will have lot of different stages. There is an antigenic variation. Only the one vaccine which has give the positive, this one is the that is a circumsporosite vaccine, I think. So circumsporosite vaccine. So this circumsporosite vaccine, because of the those sporozoites will have, so they will enter the liver, circumsporozoites. So to avoid that the sporozoites entering the liver, so if you vaccinate that person, you will have the antibodies. That antibody will bind to the sporozoites before entering the liver. That is the only one which is as on today, that is RTS-AS01 is the one that is called circumsporosite protein, and that is the vaccine, protein vaccine. So with this, as we know, the malaria is a burning this one. Now we have the, earlier we have the malaria control programs. Now the government has introduced malaria eradication program and given lot of importance to control this. And we have to, how the safety has to be taken, how the vaccine has to be taken, what is the treatment, all the protocols we have come to know. So with this I am concluding my class. Thank you very much.